One, please start, sir. We are live.
Yeah, good evening, all. Thank you very much for joining the eyesight meeting in a virtual mode. After the long time, we are doing so. So this time we have the speaker, Dr. Rutul Patel and Dr. Kalyani Bhatt. And firstly, presented by the Dr. Rutul Patel. He will present on the case-based discussion on the DME. Dr. Rutul Patel is practicing at the Ahmedabad Retina Clinic, and he has passed out from the Nagri Eye Hospital, and he is the veterinary surgeon and also visiting Curiosity Laser Center. And previously, he was visiting the Jetway Hospital as well. So, Dr. Rutul Patel, over to you.
Yeah, thank you, Noor.
Yeah.
And thank you, Bear, for the opportunity. I'll just share my screen now.
Yes.
Present the first case of use of aflibercept in DME. Basically, it's a case of 69-year female who had a complaint of dimness of vision in both eyes since long time, 6 months and more than that. On best corrected visual acuity in right eye was 6/36 and left eye it was counting finger 3 feet. On examination, bilateral pseudophobia was there, and there was some disc pallor along with high-risk PDR with florid NVs and CSME. So on presentation, the OCT, we can see there was large cystoid faces in both the eyes, and along with that, some ISOS loss was seen in left eye due to the chronicity of the edema. So patient was advised 2 sittings of PRP along with ranibizumab injection, which was given. So after 2 weeks of injection, ranibizumab and PRP, vision improved in right eye to 680, in left to 660. And edema also reduced, but it was not completely resolved. So after a month of injection, we saw the edema was recurring in both the eyes. And due to the chronicity of the disease, we advise patients to go for a longer acting molecule, that is the aflibercept. And we injected Eylea in both the eyes, one by one. So after 2 weeks of injection in right eye, the edema at this fovea resolved significantly and vision improved to 6/9 partial. I will just want to show the attention towards the upper part of the just superior to fovea, where you can see some amount of swelling was still there, but fovea was better. The edema at the fovea was resolving, so the vision improved. After 1 month of injection in the left eye also, the vision improved to 6/24 partial, but because of the chronicity of the edema and ISOS loss, the vision didn't improve further than 6/24 on Slanens. Then patient presented after 2 months with complaint of dimness of vision in the right eye, and on fundus we could see a ruptured retinal artery macroaneurysm with subretinal hemorrhage superior to fovea, the exact location which I showed earlier with some edema. So this time there was a hemorrhage, subretinal hemorrhage, and the OCT also, the edema increased with serious macular detachment in the right eye. As it was only 2 months after the injection Eylea, we wanted to manage conservatively. So I asked patient for a short follow-up and didn't inject any anti-VEGF or Ozurdex. And after a month, edema was resolving and vision was improving to 6/12. After 3 months, again, vision improved to 6/9 with the fovea becoming almost dry. While the other eye, left eye, was worsening after 4 months of injection with edema increase, recurrence of edema with vision drop to 6/60. We gave injection Eylea in the left eye, and after 1 month of injection, we can see the complete dry fovea with 6/24 vision in left eye. Even after 5 months of injection, fovea was relatively dry. There was some juxtafoveal swelling was there, but vision was good. So we are observing the patients conservatively. This was the first case. You want me to present all the cases, or we want discussion one by one? No.
Nimesh sir, how should we do?
I think the cases are a little long, so better to discuss one by one. I think that will make more sense.
Acha, but both the cases are DME related only, Rutul bhai?
No, the other one is wet AMD. This was DME.
That's okay. We can still discuss later subsequently, I feel.
That is fine. Then I'll present the second case.
Continue.
So basically, this is a case of extra large PEDs. It is a case of a 70-year female patient who had a complaint of dimness of vision in right eye since a month. Vision was 5/16 right eye. And on examination, we could see a large PED at the fovea along with SRF. The other eye was dry, showing only RP alterations with drusenoid changes. So because of the history of aflibercept in large PEDs are very good and the results are very good, we straight away went for Eylea in the right eye. And surprisingly, after a month of injection, there was a drastic resolution in the height of the PED along with subretinal fluid, and vision improved to 6/18 after a month. So we can see the difference between pre and post injection Eylea in extra large PEDs. So second Eylea was given as a loading dose, and again vision improved to 6/12 and the PED completely resolved. Then actually patient at that time actually it was 1+1 scheme available, so patient was not willing for the third injection because of the financial problem. So we shifted him to ranibizumab injection. So third loading dose was given with ranibizumab. Again vision was maintained to 6/12 partial. Then patient came after 2 months with some drop in vision, and there was some recurrence of edema, and vision dropped to 6/18. We can see some retinal fluid with fibrovascular PED. There was a fundus picture. So what should we do now? Whether we should continue on Eylea on PRM basis, or we should continue ranibizumab on PRM, or retain extend and PDT. At the time it was available, now it's out of question. So again, because of the financial constraints, we went ahead with the ranibizumab second injection. Edema resolved, vision improved to 6/9. Then patient was lost to follow-up for 6 months. And after 6 months, vision dropped to 6/18 with foveal atrophic changes. There was loss of ISOS junction in the fovea in the right eye, and vision dropped to 6/18 with some juxtafoveal edema. Now we gave the third injection of Eylea. Again, the edema resolved, but because of the central foveal atrophy, the vision improved to only 6/36. Then after 3 months, again there was some amount of edema, and we gave the fourth injection of Eylea. And after that, again fluid was resolved, and it remained stable after the fifth injection. So this is basically a case where, because of the 6 months gap between the injections, there was some atrophic changes at the level of fovea, which resulted in loss of vision, which was actually improved after the initial dose of injections. Yeah, so these are the two cases. I do have one more DME cases, but that I'll present if the time permits later on. I think we can discuss on these two first.
Okay, Rutul bhai, I just wanted to share one input. I have seen few patients right now, which have been extended on PRN basis for Eylea. So the patient took the fourth dose, and what response we saw in first, second, and third. We saw the recurrence of the disease. We saw the recurrence of the disease in 1 month only after giving Eylea. And that was quite surprising for me to see that the disease has recurrent just within 4 weeks.
That is DME or AMD?
Wet AMD.
AMD, okay.
One eye lost in AMD, another eye getting treated for AMD.
Okay.
And he's taken 3 doses, and 3 months 3 months later he came for the fourth shot because the disease got aggravated, and the fourth injection was given.
Okay.
And fourth injection later, after fourth injection, 1 month later only the disease started getting reactivated. And then I thought whether I should inject or not. I just waited for a few weeks.
Okay.
I asked the patient to come every 2 weeks, and the wet AMD started responding again. And his treatment is extended to 3.5 months with maintaining vision of 6/9 parts. But he actually had dropped to 6/18, and then he suddenly started improving, and it went back to 6/9.
Okay.
So,
Okay.
and because he's very particular, because he comes to know when the disease is getting reacted, because he's a engineer and he does the project work on his screen. And so that's why he comes to know it very clearly. So, this is what, because sometimes, I feel that changing the drugs when the drug patient has been responding because of the financial situation, it changed. But he could have gotten a very better response while maintaining on the, because we sometimes tell that they can switch because of the financial constraint. But with drug maintenance, sometimes with the same doses and same schedule and just patiently waiting, I feel sometimes the patient respond differently.
Yes. And the other thing
So
is the follow-ups are very important, I think.
follow-ups are
As
very
I said,
important.
because normally we are under an impression that aflibercept will work for a longer time. So sometimes we call our patients after 2 or 3 months of the following injection. But yeah, as you rightly said, there are cases where there is an early recurrence because of the disease may be aggressive. So early intervention might be a key in these cases.
Because patient told me that पिछली बार injection it worked properly, it worked for 2 to 3 months. This time it is working only for 4 weeks. What has happened?
Right. Right.
No, this is the problem with the free dose. No, there's no problem with the free dose. We'll just wait for some time.
Right.
And that was February, and this today it is June. I injected him in February, and this is June. He just showed me 1 week back. Still, the disease is maintaining. Very subtle SRF. I'm not treating because it is stable, and he's maintaining his vision. So just buying time and just waiting. Whenever he feels that the vision is dropping, I'll just start him on anti-VEGF again. But switching when we use aflibercept and when then we switch to ranibizumab, definitely patient shows very poor response to the drug. It doesn't show that is what it is. I feel that sometimes it is a placebo drug which is working.
Right. Maybe.
So that maybe, and yes, because initially your patient was in PCV and then it switched to wet AMD.
Right.
So it went from the aggressive disease to the lesser variant, and then the disease became more aggressive again.
Yes.
So it has changed the clinical picture only.
Yes.
So I think the RAM, the exudative PCV component would have gone, and the wet AMD would have started from some new place.
Exactly.
And the disease didn't show that very great response because of the drugs later.
Yes.
Because the clinical spectrum changed subsequently.
Right. Right. And in AMD, I think we have seen that vision may worsen very fast if the fluid is there. SRF, untreated SRF is there for at least 6 to 8 months. Like on the other hand, DMEs the DME eyes can tolerate fluid to a longer time. I think we have seen in our practice that cystoids may remain like that even after the injection with good vision, 6/9, 6/6 partial vision with cystoids at the fovea. So
Yeah. So because the
DMD
photoreceptor ISOS junction doesn't get disturbed, the vision
exactly.
still remains very good. Patient doesn't feel. We treat OCT, and I don't think we sometimes we overtreat the patient. We see the cystoid macular edema and we start treating, but patient actually doesn't have any complaint. I have one patient who is being treated with Eylea in 2023. He has one single cyst exactly at the fovea, and I'm just maintaining him with Nepal. Like that's it, and he's maintaining 6/9, 6/9, 6/9. But the cyst is not increasing, not decreasing. He's always happy with his vision.
Exactly. That is what. So I think in DMEs we can tolerate some amount of fluid. AMDs will have to be aggressive.
Yeah, AMDs we need definitely because it will snatch away the vision.
Yes. And actually, I wanted to share this DME case just because I have seen few patients where in ruptured arterial macroaneurysms, even with a single anti-VEGF, we are not getting desired results. Here, after a rupture of macroaneurysm, I was expecting the fluid may get worse or the vision may further deteriorate. But on the contrary, it resolved. Within 3 months, it completely resolved, the hemorrhage as well as the edema. So I think it happened when the injections effect was still going on. Aflibercept effect was there. It was 1.5 months, so maybe peak effect was there. And that may be the reason. I just wanted your opinion also. What can be the reason that it didn't deteriorate further?
So the ruptured RAM can behave aggressively if it keeps bleeding again and again, and if the aneurysm which has developed it doesn't settle down on its own. If the aneurysm has settled down and it has gone octocoagulable state, then it is very good that the disease is automatically regressing. Sometimes I feel after doing PRPs and giving injections, the hyaloid also starts separating from the retina. So that could be also one reason for the bleed to happen, and subsequently the bleed entering into all the layers of the retina and subretinal space also.
Hmm.
So when the hyaloid separates, the bleed also goes away and the fluid also goes away and the disease start regressing. So that is
Yeah.
also one phenomena we see, that when the hyaloid is very taut and when it starts separating, it ruptures and it gives us a hyaloid bleed or a subretinal bleed sometimes, or in all the bleed in all the layers of the retina,
And
subretinal,
as I
intraretinal,
mentioned,
everything.
after this rupture of mechanism, particular that eye has gone very quiet. I have followed for almost 6 to 8 months now. There is no recurrence of edema. Like the whole thing, I mean, the rupture of the mechanism, the majority of the inflammatory factors have gone down now.
Yeah, so and second is HbA1c getting under control, and patient on insulin with an anti-inflammatory factor actually responds really very good, and they don't show recurrence of disease so soon.
Yeah, but the other eye is having had a recurrence even after 3-4 months of this. But this particular eye, where there was a rupture of mechanism, has gone quiet since almost a year now.
But then your NVD component was more in the left eye, I think.
Left eye had a chronic CME, so there was some ISOS loss at the fovea. I'll just show that OCT, initial OCT also, the first OCT when we started the treatment. Yeah. Here itself, the left eye was having a center area defect, I mean the outer layer defect, ISOS defect at the beginning of the treatment. So that's why the vision was less in that particular eye. The edema component was more in right eye, but that was recent. Left eye was little more chronic.
So he would have started treating only when the right eye started having problem. He was not
Exactly.
worried
When the
about the
bleed
left eye.
got involved and she came for treatment.
Hmm. Right.
Yeah.
Anybody else? Shamal bhai, Harth bhai,
Most
Daivat
of
bhai,
the important factors have been discussed. Nothing more for these cases.
Bhavik bhai. If not, then I think we can switch to Kalyani madam's case.
Hello everyone.
Hello, ma'am. Please. Good evening.
I thank Bayer for giving me the opportunity. Am I audible?
Yeah, ma'am, you're audible.
Actually, the screen share screen option is not coming. How? From where it will come?
Rutul bhai has to shop share screen.
Tech team, can you please help the ma'am?
I've already stopped.
Okay.
Ma'am, are you able to see now?
Yes, now it's coming. So, is my screen visible?
Yes, ma'am.
Hello?
Yeah, ma'am, it is visible.
Okay, so today I'm going to present a case on aflibercept in wet AMD. This is a case very interesting because the patient has taken multiple injections over the span since 2022. A 60-year-old male presented with a complaint of reduced vision in right eye since 3 to 4 months. He had already had an history of Eylea taken 2 injections before presentation for neovascular AMD. Right, both eyes IOP were normal and BCVA was 6.9 and 6.6. Right eye, there was a pigment epithelial detachment with hemorrhage around it, and left eye it was dry AMD. OCT, both
Ma'am, sorry
eyes.
to interrupt you. Actually, your screen is not moving. Anyone able to move? See, or only I have the problem?
No,
Can you
screen
switch the presentation
No,
mode?
it is not. It's a presentation mode is not on.
Ma'am, can you please on the presentation mode and then
Okay.
now please switch the slides. Okay, now it's visible. Yeah, okay, now it's going.
So the OCT of right eye showed pigment epithelial detachment and left eye showed RP alteration. The first injection I gave on 18th of October 22, and the yellow arrows in the presentation denotes the injections, and the OCTs are showing with the dates which are labeled with the OCT. So second was given in November and third was given in December. So we could see that the PED was same and the SRF was same. But after that, the injection was given in February, March 23, and then the SRF had reduced. Again, the patient was stable for 4-5 months, and there was a recurrence of SRF in August 23. So injection was given in September 23 and October 23. Again, the SRF had gone down. Then it was stable in January and February and March 24. The SRF recurred in April 24. The injections were given as the arrow denotes, like in December 23, January 24, and March 24. So again, the injection Eylea was only continued. I had asked the patient to switch, but he told that no, I want to continue with Eylea only. So to my surprise, again the SRF responded very nicely, and in June, July, the SRF again gone down with a reduction in the size of the pigment epithelial detachment. And in October 24, he took the last injection. It was the 14th Eylea in his right eye, and there was reduction, or there was no recurrence, and the PED height had also reduced. So after that, he is only on the follow-up. These are the last 3 follow-up scans in January 25, May 25, and March 26. All the scans shows no SRF in right eye, and the PED had reduced in size significantly. After that, he has not taken any Eylea, and right eye BCVA is maintained at 612. Left eye is 69 with dry AMD. So thank you. This was the case.
That's a really wonderful case, and I think a very long follow-up across many years.
Yes,
And,
that's why
and,
it's interesting.
it really says us the importance of treat and extend in patients with PEDs and this. So subsequently, the disease had subsided. Is disease-free for at least 1.5 years.
Yes,
So we expect that the disease should not get back to activating mode, but it will get activated subsequently. We also know about it. It is the lucky honeymoon period of the disease, where the patient is quiescent and the patient is not requiring any treatment. So it happens across many years after taking patients regularly taking follow-ups and regular injections. Yes, patients do really very well, and this is actually very good with IELTS. We do not see that very great response with ranibizumab in spite of injecting many times. The disease responds and it comes back again within 1.5 months. But IELTS shows a dramatic response, and it shows that we can increase the follow-up and decrease the number of injections. That's really there. That is why input, and we are really seeing it. But we have patients across many years now. We have actually seen the quiescent stage right now. So it is happening.
actually, the Eylea support program helped to this patient. Like the 1+1 and 1+2 was very supportive for the patient. So he took the Eylea regularly.
So now Noop should be behind it to get the support program initiated again. He's not doing it.
Now, sir, we are very well, want to do it again, but we will do it with the 8 mg.
So 8 mg will be more expensive. How will the patient afford?
No, Dan. With the patient program, we are trying to, good pricing with the 8 mg as well. Company is trying, so let's see how it works out.
So let's see.
My message is, actually we humans are very resilient and we are very adjustable in nature than what we think. So even if the petrol rates have increased from 90 or maybe even 80s in last 5-7 years to 103, but still we are traveling in the same way. We are doing our business in the same way. Everything is same. So even Eylea, when they will come up with a higher price, I am sure initially there will be resistance, but eventually everybody will blend in, and after a few years probably we will be doing a similar CME, and we'll be talking that how 8 mg is beneficial.
That's a very good thought of yours. So the durability should increase if in case they're increasing the dose. We expect the durability to increase and the price to be reduced. So let's see. And it was a very wonderful case. Anybody want to share any inputs to this case? Rutul bhai,
Yeah,
Hard
wonderful
bhai.
case actually. Very, very long follow-up. And Dr. Karyani, can you show the initial OCT with PED, the first one? Yeah.
This was the November 22.
Okay. Here you can see this. This is a fibrovascular PED. Normally,
Yes.
this kind of PEDs after, or particularly aflibercept, which are more potent, the chances of RIPs are also very high. But fortunately, in your case, the resolution was very slow. That's why you didn't develop any RIP, RP RIP.
And you went away without scarring.
Yes.
That was a very good thing which you had seen.
Yeah, the vascularity below the RP is very, it's very vascular.
It
So
was
she's.
a fibrovascular PED. Yes.
So you are lucky. So it went without a scarring and a bleed.
Yes. Patient was lucky actually, and I was.
No, but sometimes when you treat timely, I feel the chances of bleeds decreases. Once it starts bleeding, the scar do develop eventually. It is only when they don't bleed and it's only a serous detachment or a serous fluid connection. That's when the patient gets a very good response. But if it starts bleeding, we don't get the response what we want. It is only the SRF collection which responds really well. Bleed responds a little nasty way.
Yeah. So anyone is doing anything different in this kind of fibrovascular PEDs, large PEDs like half dose or like I have seen few papers where they are doing it at half dose, and in some they are also doing it at half monthly interval to reduce the chances of RIP.
But does it really makes any difference? But even if in case you give a full dose, RIP, if in case it has to happen, it will happen with anything. Even if you inject fluid, I think it will happen.
That depends on how fast the CNVN complex resolving. I mean, if it is slower like this case, you can see the gradual reduction in the size of the PD, then it's fine. Then it's not going to induce any RIP. But if there is a fast reduction in the CNVM, which is actually aflibercept is known for, so there are chances that may get a RIP. So, I mean, if I wanted to know anyone else is doing anything different in this kind of cases.
I actually don't inject Ilias very frequently, at a very 1 monthly interval. I give a very good gap. I just
Okay.
keep the patient on follow up, and PED patients I generally keep a very good follow up. I keep them following up between 1 to 2 months, and then when I feel that I need to inject, that's the time I inject. Otherwise, I don't follow that 1 monthly regime. I just keep waiting to see
Okay.
what is happening. Sometimes the PEDs don't respond very good. Sometimes they responded very fantastic. So easily waiting for 1.5 2 months also doesn't change the disease course. It responds really well, and when the frequency of injections do come down. So instead of the injections required in first year when they are 6 to 7, it comes down to 4 to 5. So I increase the gap between the loading dose only after I see the response with the first injection. If in case I feel the response is really very good, I do not inject it 1 month also, 1.5 months also. I easily wait for 2 months.
Okay.
So that is how I feel that the chances of RIPS goes down the PED subsequently because we know that the Eylea is going to work for at least 2 months. It is only on the follow-up we come to know whether the disease will be behaving very badly or very nicely. I
I
do that way.
also have one patient. She is taking Avastin from me, and she is also having similar wet AMD. Typically, her SRF comes typically after 2 months. Like 1 month छोड़ के 1 में उसको लेना ही पड़ता है इंजेक्शन.
Sometimes you see a very good response in PCV with Avastin also. I don't see that response with ranibizumab, but yes, Avastin it does wonders sometime in patient with PCVs. I don't know why, how does it work, but ranibizumab से ज़्यादा better response Avastin में आता है with PCVs. I don't know that is my experience or everyone else's experience, but ranibizumab से ज़्यादा better Avastin काम कर रहा है. I go one step down to try, and then they respond.
Sir, do you have any experience when you have used aflibercept and also Vabysmo in same case or switch to Vabysmo or
Very rarely, very rare. I generally don't change the drugs, then I don't see a tachyphylaxis effect or I don't see the response. Till then, I don't switch the drugs. I have patients since many years on idea. Rarely I would have changed if the patient would have insisted, I want to change the drug. If the patient has traveled abroad and they want to change it, that's when I changed. Otherwise, I don't change. I always tell them one golden dialogue of mine कि जिनके दो तीन दवाई ही है, बार बार बदलते रहोगे तो पुरानी वाली दवाई काम नहीं करेगी फिर. तो पेशेंट ऑल्सो रेजिस्ट कि नहीं बराबर है, रहने तो यही बराबर है. So I always do that part. Anybody else wants to contribute anything or their inputs about the thing? If not, then Nubhai, make a ending note.
Sir, there is one surprise from Kalyani ma'am. She wants to present one video on the myopic hole. So,
Please.
yeah.
It is macular hole.
Sorry, macular hole. Sorry, macular.
Yeah, please continue. Please continue, ma'am.
Yeah. So
Actually, I have to go out. I've got some guests at my home, so I am taking exit. I'm sorry, and thank you for the meeting.
no issue, sir.
Okay, thank you.
Thank you, sir. Kalyani ma'am, you can present the video.
Yeah, this is a video in which I have shown the surgical technique for the inverted ILM flap or ILM flap for large macular holes, because usually we encounter the macular holes which are less than 400 micron, but those holes which are more than 400 micron, these holes are difficult to close. So this is just a 5-minute video of the surgical technique.
Ma'am, are you sharing the video? Because we are just seeing the presentation right now.
Sorry?
We are seeing the presentation. Your earlier presentation is visible to us.
Okay, I'll share the screen again.
Okay, ma'am.
Hello?
Yes, ma'am.
एक second. So is the video visible?
Yes, ma'am, it's visible. Yeah. Good.
Audio?
Yeah, audio is also coming.
It was the first case of 74-year-old with PCOS. Core vitrectomy was done, IPPA was injected, PVD was reduced. Peripheral vitrectomy was done. PPG dye was injected. And large 831 micron macular hole was done. So ILM peeling was started by pinch and peel technique, and pinch and peel was done started from inferior. The temporal flap and nasal flap has been removed. This is like star flaps or cabbage appearance of the flap, like a flower. All the flaps are attached at the margin of the hole. Now the temporal flap was folded over the macular hole and was the area of INF and fluid and exchange was done. This was the pre-op OCT showing 831 micron, which was closed, and BCV improved to 680. This is the case 262 female who has BCVA 660, 793 micron large macular hole was there. Here also pinch and peel was used and nasal flap was created. First, and after that temporal flap was created. Now there was a little bit of more breathing done, and in that breathe I lost the temporal flap which was stuck in the hole cell. So now I had the nasal flap which I inverted on the hole and little bit stuffed inside it, and the macular massage was done with the soft tip and fluid exchange was done. But luckily the post-op OCT hole was closed and BCV improved to 624 from 660. Thank you.
Thank you, ma'am, for the wonderful video. I think
Yeah,
Nice video, Dr. Kalyan.
thank you.
Where the bell is?
So any points from the audience? So anybody wants to discuss anything regarding the macular holes, large macular holes?
So if anyone have any questions, they can ask or they can put it in the chat box as well.
If there is no question, I think we are good to close.
Yep.
And Shetty Rutul, sir?
Yeah, okay, Noop. Yes.
Yes, yes.
Kalyani
So,
ma'am, anything from your side you would like to share or something? Or like
No,
we
no,
are good?
I just, I mean, if anybody has anything to discuss, then we can discuss on it, on the topic.
So I think there is no question in the chat box as well, ma'am.
I mean, okay then.
So Noop, can we close the meeting then?
yeah. So tech team, we are good to close.
Before that, thank you so much, Dr. Rutul and Dr. Kalyani, for presenting wonderful cases. And the video was also very nice, ma'am. Thank you so much.
Thank you. Thank you, Yash.
Thank you. Thank you,
Thank you,
sir.
Yash. Thank you, Noop,
Thank you,
for
Noop.
giving
Yeah.
me the opportunity.
Yeah. Thank you, ma'am.
Yeah.
We are offline.